Hey guys, do you work in emergency medicine? An absolutely crazy and intense environment where you see things every day that a regular person doesn't see once in their entire life. Do you feel burned out, unappreciated, like there's no one you can talk to about the things you are struggling with? Well, you are not alone. I have a bunch of real professionals with real stories here with me today that can relate to your struggles. I've struggled with burnout, discouragement, and frustration many times and still struggle with it occasionally. My name's Aaron. I've been in emergency medicine for 15 years as an EMT, paramedic, and now emergency medicine PA, and I am the host of the Practical EMS podcast. We've got some new guests with us today and some returning, so we're going to jump right in and do some introductions and talk about some awesome topics today.
My ex always asked me why I did this job, and I said, because it's always going to be there. You know, I built houses for a while, and we had a huge housing slump. Yeah. And so I had no work. But anyway, I think that I agree with some of the stuff he says as well, but I don't agree with I think you make your own morale. We used to do these videos that every year when we'd have an awards ceremony, and Matt would put these videos together, and they were like awesome videos. And one year he decided he wanted to interview paramedics, dispatchers, EMTs, and ask them what was special about the job. And one of the PAs that works in your ER used to be a paramedic, and I used to be married to. Tracy, she said something that was so profound in that video. And when he asked her that question, and she said, and you could tell it was she had to think about it for a minute. And she said, one of the things that's really great is that we have the privilege to be with people on their worst day. And, you know, you sit there and you think about it, and it's like, that's so profound, you know, that you have people that care, that are going to take care of patients. And that's what's important to them, is to be there for that patient during their worst time, and to be able to care for that person. And so anyway, it's when you have that kind of thought, your morale is way up here.
Way different.
Yeah, so much different, because all the other crap, all the superfluous crap, the compliance, the insurance, when I say superfluous, it's not. I mean, we've got to get paid, right? To stay in business, and to get paid personally. But
you get paid?
I get paid. I get paid pretty well, actually. But we have to put up with those things. Yeah. But if we can keep our mind and our sight on what's really important, doesn't matter if they're, like you said, they've got Medicaid or they've got the best insurance in the world. It doesn't matter, their socioeconomic level. Right. If you can look at that patient and say, this is a person, and I'm going to do the best that I can do for that person, no matter what their status, no matter how sick they are, how not sick they are. It's their emergency, not mine.
Yeah.
Right. And as long as you can keep that in mind, I think your morale is much better, for sure.
I think some of the negative morale can also come from like kind of like what both of you gentlemen just said, we're here to try to help out the best we can. And then like what you were just saying, if you have that mentality that you're there for them, I think some of the negative morale can come from, especially depending on where you work, that you have a game plan, you have a treatment, and then you want to do it because you know it would help them, but then you get shut down due to other responder reasons, and it becomes almost like a political game. It's like, I know what I need to do or how I can help this person, but since another individual doesn't see it that way, I can't do it. And then if you do it, you get in trouble. I mean, or you don't. Yeah. And it's ridiculous because I can give you a real quick example. We had a woman who was an AFib and RVR, ran out of her Cardizem, called, and she was ticking at 190. We have Cardizem to fix the problem, but the other individual said that this woman wasn't symptomatic, and she had chest pain and dizzy. Now, I know I'm just an EMT, but that sounds like symptoms to me. This individual literally rode with us to the hospital to make sure we didn't do it. And then they ended up having to screen her for a stroke. And then they ended up having to shock her because she was an AFib for so long, she went into shock. So, like, I think that's where some of the... They couldn't because her BP tanked. Yeah, her BP tanked so much.
You didn't have a doc riding with you, did you?
What's up?
Didn't have a doc riding with you, did you?
Nope.
I've heard some stories recently with some of our young bucks.
Yeah, no, it wasn't that. It wasn't. There was no doc. But, like, I think some of the negative morale can come back from that because it's like, you know, we have the technology and like we know what we want to do to try to help these people to help them, but then we get shut down. Or, you know, because like, I mean, I know most of you guys know, like I joined medicine for the bipolar or the suicide stuff. So I can sit here and talk to a lot of people about this, but like the negative morale to me comes from whenever someone just straight medicates someone without talking to them as an individual. You know, I couldn't tell you how many times I've been on scene and the department's like, I'm just going to drip Paradol or I don't fucking care. Or like, I don't have time for this. Or like, she's just bitching about her life. I'm just going to Versed her. Okay, let's figure out what's going on. Why is she crying? Why is she pissed off? Like, why do we go straight to medication? You know, so I think that's where some of the burnout on me came from. And I think that's what's nice about the ED now is I haven't, like I can sit there, like for one 12-hour shift, I was watching someone on an M1 and that whole 12 hour, I just talked to the person. And by the end of the day, like, you know, he cried, he hugged me and we were joking around the whole time. Yeah. So
only in the ER will you get stuff like that.
Yeah. You know, so like, it's kind of like what you said, I think it was the first or second sentence, like no one's going to stop me from actually helping somebody. And it kind of felt like through my 9 years on the rig that I was being stopped all the damn time from helping someone. So I think that's where my burnout probably came from, for sure.
And that comes from someone else's burnout, right? Why don't they care? Why do they just want to give a drug? And that happens to docs too.
I think some of it too comes from like the education system. I mean, I went to nursing school. I started in 2010. We were taught this like picture perfect. Only people come to people that are sick want help. Not always true. Not always true. Yeah. And once we have once we find out what the problem is, we can fix it. Also, not always true. Yeah. And people die. The only way out of this life is death. So we can't fix sometimes a ruptured aneurysm that's gone too long and we sit there and we watch it. And that can lead to some of this stuff. But also when you train and school teaches you the idealistic, perfect view, and then you get slapped in the face with reality in practice. Some of these new grads that come right from nursing school into emergency medicine, that's a school of hard knocks right there. You are learning about drugs and alcohol because we don't learn about a CHFer who blew her heart out on cocaine and meth in school. We learn about that as a disease process. We don't talk about what caused the disease process. Yeah. So then you feel like you're having all this moral injury because you can't fix her when it's not a fixable thing anymore. Or, you look at the education that people come from or, internists, and if they're constantly told no, or some of the specialties ordering drugs from insurance companies, and they were throughout the whole time told yes, 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 driven in a perfect world to the school of hard knocks, that could probably do it.
For sure. You picture the internist who is told by the government, you have 10-minute appointments all day. I don't care if they're crying. I don't care if they need a test. You have 10 minutes and you will see X number of people a day. This society needs it. Okay.
Yeah.
Yeah. Yeah. Or they teach you, here's 150 drugs by brand name that treat all these 150 conditions. And then you get out there and get a prior auth notification that takes 3 weeks and the old person's dying. Mm-hmm. As an internist,
and you're picking up that phone because you are doing everything to get that patient their drug, and you can only move as fast as the person on the receiving end.
Right. Those things,
so those things. But I think that you covered it. That's the beauty of emergency medicine. We can't be denied some of the stuff that we do. Yeah. But I can see the moral injury on the other end, either education or specialty.
Yeah. Mm-hmm. And that's where he's coming from, a lot of that.
Yeah.
That I didn't think about it in that context at all, but I think because I can spend a half hour in a room if I want to.
You could.
I can spend 5 minutes in that room if I want to. Yep. Like that, I feel like so much of it is in my control that if I have a patient that's going through something tough and I'm connecting with them, I can stand there for a half hour if I want to. The department's going to keep going without me for a few minutes.
That's right.
You know, I mean, there's some patients that are dying and we gotta go immediately to those, but a lot of our days within our control. But I think you're absolutely right. It's getting these prior authorizations for certain things and all these other barriers they come up against that we don't really see in the ER because we can order whatever test I want. I mean,
And you could treat this small scenario I'll give you as moral injury, or you could treat it as something that boosts your desire to do this job, emergency medicine in particular. I can get behind in a department by 15 minutes and have by sitting with the spouse who just watched their significant other die. And you can be the shoulder they cry on if you want to be. And that should be part of the reason why you were driven to do this job. Now, you can call that a part of your burnout, then you weren't made for this.
Nope.
And that's okay. But if you're made for this, you should hold on to that.
Yeah.
What a gift. And we do that. Nobody else has time or the patient to do that. They're not going to get that person. We will.
yeah.
So you better hold on to those moments and let that be a part of the repair to your injury from the system that you work in. No other person had that gift. We get it, not infrequently.
That's the other thing that Tracy said on that video was that we can sit with that person who just lost somebody and tell them that, you know, I was there when they died and they didn't have pain, you know, because we took care of that. And so I think one of the problems that we don't train people or talk about is how to handle sorrow. And I think people get burned out because of that. It's because they can't handle that. And like you said, if you can't handle that part of it, this probably isn't the job for you.
It's okay. Yeah.
And we see that a lot in this job. You know, we've got so many people that have ended up killing themselves over that particular part of this job. Here in town, we've had several, and they were really great paramedics. I mean, really outstanding, you know, water walker paramedics that they just couldn't handle the sorrow aspect of it.
Yeah.
And
Yeah. We're all different
Yeah.
that way, you know?
yeah,
You look at the number of docs that committed suicide because they watched so many people die of COVID.
Yeah.
And then some of us in particular just moved on.
yeah,
You went, damn, I watched 3 people die in one day today over this and I couldn't do anything about it.
yeah,
But nobody else could have done any better. That's what I can take from it. Okay. Tomorrow. You just have to know who you are.
yeah. You got to know that you've got limitations.
Yeah.
I think that's one of the issues as well, is that you get into this business and you think, man, I'm great. You know, I'm really good. But everybody's got their limitations. And if you can't understand that, you tend to get crispy.
Yeah. That's why you should go into emergency medicine and not be a surgeon. Speaking of crispy.
Does anybody else have some comments on the video?
I didn't see it, but then
But your summary was excellent.
yes,
Yeah,
it
the
was.
quote
It
kind
was.
of
Thank you very
encompasses it, yeah.
I did watch the video,
Oh, thank you.
but rug
Show
throwing.
Show
That
off.
was the part that I wrote down though. Like, we did go into this. We are loving human beings. We show up on their worst day. It's okay to tell them, I'm here on your worst day.
Yeah.
Because sometimes that acknowledgement too goes a lot. Like, this is your worst day. You think it, you can feel it. This is it. Everybody has to have that bottom. This might be yours. And we're here on that day.
Well, I think there's a stigma, especially in the pre-hospital area. You know, I'm not a hand holder. Well, horseshit.
What if you are?
You
Is
should
that
be.
bad?
You should be a hand
Yeah.
holder.
Right.
I mean, maybe that's all the person needs at that
Yeah,
point in
for
time.
real.
Or that's all
Most
you
people.
That's all
Yeah.
you can give.
Yeah.
When that AAA is
That's
in front
right.
of you
Yeah.
and they are writhing in pain and
Yeah.
you're doing everything, all of those fentanyl pushes, and you're barely hitting it.
Yeah. Sometimes it's
You
just a
have the
touch.
nurses panicking running around you, but what you need is to hold that family member's hand
Yeah.
and give that family member a tissue box and
Yeah.
say, this is it right here.
Yeah.
Say your words.
Yeah.
Not everybody gets this opportunity. You can call out these feelings and things that for them, like, we are loving human beings that go into this profession.
Yeah. I think we build a huge callus around ourselves,
Yeah.
but sometimes you have to break through that callus and just be a human.
Mm-hmm.
You know.
Yeah, that's a good point. I think a lot of people end up losing that, you know, over time and maybe rediscovering it later. Because I mean, I've had times where like you're just here to do the job, you're here to collect a paycheck, especially when I was burned out as a paramedic. Like you just go in and go through the motions. And then I think when you have some time to reflect and you're like, I got into this job because, ultimately I love people. I want to help people. I want to heal people. And you kind of lose sight of that and then can kind of come back to it. Because I feel like that's the point I'm at again, where like you're here to serve people. And that's why we all go through this brutal education process, is to help people. And I think it's easy to lose sight of that in the midst of everything else. So I definitely agree with his statements about that. I mean, that's super true.
Well, you doing this podcast is evident.
That's true, right?
About
Taking your time.
not only do you care about the patient, but you care about us.
Yeah.
You care about the docs, you care about the nurses, you care about the PAs, you care about the paramedics and EMTs. And, so.
Yeah, I mean, part of the goal is to heal the healers, because we just, on shift, we have no time to talk about stuff at all. Like I saw Kylie a couple days ago and we said like 3 words to each other because we're all getting our asses kicked. Like there's something constantly to do. I can't sit and talk with the crew that brings in a critical patient for more than a couple minutes because I got, a list a mile long of tasks I need to go finish.
And they're going on another call.
Yeah, and I want to, exactly. Like they're getting called out and I want to talk to them and be like, you guys did a great job on this call. Like that call really sucked. Like you guys are going to be thinking about that call for a while. Like that was really brutal. And they're like, oh, we got a call and I got to go put in orders. And like, we have no time on shift to talk about this stuff. And that's part of the reason why I do this.
You got to maximize those opportunities though, when you do get those chances, because they're so few and far between, because you can't do those things. And I always, if I possibly can, if I run a call with our other responders here in town, I don't know how many people do this, but we especially if they don't write in, they don't understand sometimes what happens. And I will call the paramedic supervisor for the fire department and say, listen, or I'll call the station and say, listen, these guys did such a great job on this. And it goes so far with our providers, that sometimes it's a thankless job. And when somebody takes the time to follow up and talk to them about those things and say, hey, this really went well, or, hey, we completely missed this too, and I can see why we missed it, but this is what happened when we got to the hospital. It goes a long way when you can maximize those opportunities, because like you said, we're so busy, we're getting called out, you can't necessarily give us any feedback, and you may want to, but you don't have time because you're putting orders in and so on and so forth.
Yeah.
So, yeah.
And it means more coming from a colleague,
Yeah.
Patients thank us a lot and that's great, but it means a lot coming from your colleague.
I'd much rather have Adam say, hey, Casey, you did a really good job on this. Or him say, hey, we need to talk. You completely missed this.
Right.
I'm going to take it much better if we have that kind of relationship where we can talk about both of those things.
Yeah. Mm-hmm. Instead of it like trickling down from your chain of command or your CES, like, oh, you missed this a week ago, by the way. It's much better to get active feedback in the moment.
I'm going to talk to Adam about that. Why didn't you? Yeah.
He's way more likely to reprimand me than me to reprimand him for something, for sure. But what you hit on there is key for everybody to know who goes into this field from the field to the department. I mean, there's one way to help everybody with moral injury and burnout. Shaking a hand, taking 30 seconds to say, that was nice work. Yeah. It goes miles. Yeah. Like, I tell you right now, if a nurse comes up to me and he goes, I don't know how many times I've seen a doc say or do that. That was awesome. You're like,
what?
Whoa.
Yeah.
The higher you go, by the way, it's not a hierarchy. It's just what I mean is positionally, like paycheck wise. How about that? The higher up you go in this, the less likely you are to get a compliment, believe it or not.
Yeah.
Like, people will not tell you nice work because we're all doing the same dang thing. You're expected, right? Mm-hmm. So when you take someone who's expected to run the show in the field, a paramedic who has a rough run, and you say, man, that would have been tough for anybody, me included. Yeah. Whoa. It goes for miles.
Yeah.
Helps everybody last another day in the job.
Yeah.
So keep that up.
Treating each other with respect and like just being nice to each other during shift. I mean, there's a lot of people we work with that are just like treating each other like crap. And it's like, this job's hard enough without...
You're literally just putting oil on the fire.
Yeah. Just be nice to people. Don't be condescending to them and to the patients. Like, I mean, I think it goes a lot of different directions, but Like it means a lot when we can all we're all under the exact same stress. It's all it's all a lot of stress. We're all feeling it. And so we all should be able to respect each other and treat each other nicely in the midst of all of it.
And that's without even bringing, because I mean, we all try not to bring home stress in, but it's still there, you know? So that's not even considering at home shit going on.
Exactly.
And then you go to work and then just like what you were saying, everyone's talking bad about each other, or like all that stress is just building. Yeah. And literally just like what you three are just talking about, like a good job goes so far, like, but it feels like the negativity outweighs the good jobs. Like you don't hear it enough. You know, it's like if someone can't get an IV and you're like, man, that was a good ass IV. Good job, Aaron.
Yeah.
You're like, heck yeah, thanks, dude.
No one said that to me in at least 4 years.
Yeah, exactly. Yeah, because you have people for that.
Everything you hear today from myself and my guests is opinion only. It does not represent any organizations or companies that any of us are affiliated with. The stories you hear have been modified to protect patient privacy, and any resemblance to real individuals is coincidental only. This is for educational and entertainment purposes only and should not be taken as medical advice nor used to diagnose any medical or healthcare conditions.
Casey, do you remember when we ran that you brought in an altered lady and she definitely had ETOH on board and you were like, there's more.
Yeah.
Morgan and I were off shift. They didn't have any nurse to do it. So Morgan and I came back and we started running it. We're like, she's got a big old bleed. Yeah. She has to. And you sat there with us and we did it. It was just the three of us. Finally, we get a doc to come in and we were like, hey, she needs a tube. He dropped the tube. We were in scan and we were done with it and wrapped up in a recess bay by 25 minutes.
Yeah.
Wow.
And it's like, you aren't even employed by this place, but that's what we do for one another is like, you said, there's something going on. Morgan and I are like, well, shoot, it's coming from Casey, so it's probably right.
Oh,
Dang
God,
it. I said, all right, I'll put my bag down.
It's either here or it's here.
Yeah. It's either spot on or way on.
Well, and there's different levels too. You know, there's the aspect of we've got to do right for the patient, right?
Yeah.
But we also have to do right for each other,
Mm-hmm.
you know, and support each other. And, you know, there's so many different levels. It's like an onion, you know.
And each time I'm just crying.
Yeah. Well, that's okay too.
Thank you.
Okay.
Yeah. I get teary doing these.
Yeah.
Sometimes.
There's
Yeah.
nothing wrong with that.
Yeah.
No,
There's nothing wrong with that.
no. That when Les was here, you know, he was like, I'm not crying. You're crying.
It's your fault.
Yeah.
I wanted to talk a little bit about leadership in emergency medicine because regardless of your education level or where you are on the bullshit hierarchy, that's actually one of my other principles is the hierarchy's bullshit.
Yeah.
But wherever you fall on
It's a
this
friggin' team
imaginary hierarchy, I think we all have the opportunity to lead, and we're often put in those opportunities, especially in the field. I mean, you don't know what you're walking into. If you're on a BLS car, you're going to be leading. You know, a lot of times the paramedics will take, you know, the lead on the scene. But what if your paramedic's having a bad day and they're not thinking clearly and they're new and they freeze up? I mean, regardless of your level, you're going to have the opportunity to lead. Even in the ER, if we're getting slammed and a critical patient comes in, I may not even have a physician there. Part of the thing that makes my job a little easier is I usually do, but sometimes they're not there. And so we all have to lead. And I'm wondering if you guys have any specific stories about leading in EMS, whether you saw a case that was really good and, you know, reminded you what it means to be a good leader in this, or something you did or something you saw. A brief story I have was when I was a paramedic student, I was actually doing a ride or a phase with the fire department. And the fire medic was, I wish I could remember his name. He's awesome. He's like well respected. He's in an admin position now. We were at one of the stations and on their squad unit. So we're going out in their kind of little ambulance vehicle on calls, but not transporting, of course. And we went on this call and it's this lady's catatonic. This young girl's catatonic. She's breathing fine. Her pupils are fine. There's really no reason why she should be unresponsive. Her oxygen level's fine. This is kind of a psychiatric thing, right? We don't need to be aggressive. We don't need to torture her with IVs. We don't need to intubate her. You know, she's not a suspected overdose. So we're just going to bring her to the hospital. She's probably going to perk up. Well, the private ambulance medic said, hey, let's restrain her and nasally intubate her. And this fire medic said,
Pause there.
and this fire medic looked at him and goes, we're not going to do that.
Yeah.
And that was the end of the discussion. And I'm a paramedic student. I'm like, whatever you guys are down for, I'm here to do. I don't really know what's going on here. She's unconscious. Maybe we should be intubated. I don't know. And so we didn't intubate her or anything. And, it turned out, she was catatonic for a psychiatric reason. They gave her some time. She woke up. There was no reason to be overly aggressive with her, right? And especially do something that's going to torture the poor girl, like restrain her. And, and now with my experience, I'm like, of course that would have been absolutely inappropriate care. But I look back at that as a good leader because he was firm in what he decided to do. And it was the absolute right call on this particular patient. But I think it takes a lot to say, I think it's easier to go with a stupid plan and we're all on board. I guess we're doing this. And I think it's harder to say, no, we're not doing that. For sure. And so I always look at that as kind of a good leadership. And this guy went on to be, admin in the fire department and go on to do leadership things. So it's, that was definitely his strength. What do you guys got on this?
I'm getting ready to take off on you. So I'm going to say one thing on that comes to mind. Why every level in emergency medicine, meaning in the field, in the department, doesn't matter, why it's important that everybody should have it in them to be prepared to lead in some way. Yeah. It's important, and this goes back to the whole moral injury thing and burnout. Why I think it's important, personally, this comes from my position as a physician. I think that's eminently important to lead in times that are a real struggle. You probably ought to bring the best of what you've got, the best of the knowledge you've been given and your skills. They better be ready to be deployed to the max when you've got like a code, a surgical catastrophe without a surgeon around, the sickest of the sick patient. Things in our job go south sometimes. Not everybody makes it. The importance in those times that I've found of being, I'm not talking about just myself at all, having a good leader or what people visualized afterwards as having been a good leader is important because everyone else can take some of that weight off their own shoulders and project it there. And that's a good thing. Doesn't mean that the person who was leading has to bring it home or feel the weight of the things going south. When I've had a code that was unexpected, for example, and they did not come back, when everyone feels like that was led really well, it was structured, I think we did everything we could do, they can go home and sleep and do it again tomorrow. Mm-hmm. And the person who led doesn't have to carry any extra burden that he just received from everyone, he or she. They can say, I think we as a team did the best we could have done. And in this job, shit goes south sometimes. You can't save everybody. And I will get some sleep too. So the importance of a good leader from the field to the department is invaluable when things don't go well, assuming that you did what you do well. Because everybody is welcome to just pass that grief up the chain and say, well, I think it was led really well, so what else could we have done? Nothing. So get some rest, because this will happen again. If you don't, we've all heard plenty of stories, and I can think of many examples, and I'm sure I was probably a part of some of these and don't know what everyone said. But there are times when you hear, this was led in a way that I don't know. Why didn't we do X, Y, or Z? Nobody talked about it. Why, when I brought up, was I not listened to? Why, hey, was there ever a time no one ever stopped to debrief and tell me afterwards why this was done this way? I'm not sure I feel good about that. Mm-hmm. You let those things go, everybody burns out. And nobody wants to come back and do it again with the same team. Or maybe at all. So it's a high risk, high reward position to make yourself a leader and say, I'm going to do what I can do in my role to the best of my ability. It will help everyone. Mm-hmm. I think that's why it's important in EM, because not every day goes right. Mm-hmm. Yeah.
I agree. I think that you have to have some humility and be able to take criticism on the fly as well. Yeah. I remember working down in a town south of here when I first started. We had an ER doctor, and if anybody is watching this right now and they saw me do this, they would know the doctors I'm talking about, because we would get bring in a cardiac arrest to the ER, and we would run through the scenario, and we'd run through the code, and we would do the things that need to be done. Right. And he would go around. This is a leader. right? He's a leader. The reason he was a leader is because he would go, Casey, what do you think we should do? Do you see any bases that we did not cover? I'm a paramedic.
This is where it came to you, right?
Yeah, he's the doctor, but he's already done all the things that has come to mind, and he wanted to check with the nurse, the medic, the EMD, and say, hey, did we miss anything? Before I call this, did we miss something? That's what a leader does.
Yeah.
And Dr. F, what do you think about this? Hey, that's not a bad idea. It's kind of it's on the fringe. Let's try it. I think that's one of the things about being a leader. I think one of the other things too is that you have to, like you said, you have to be a leader at every level.
Yeah.
At every level. And I think one of the big parts about being a leader is that you have to take ownership, good or bad.
That's right.
Good or bad. And when you have something that's good, you pass it off. You pass it off to the rest of the team, right? And if something goes wrong, you own it. And that's what makes a good leader. And that also combats that burnout, if you can do that. Because when you do that, you build respect. And, I'm not like tooting my horn, but when I first came to this city and started working in the 80s, I had a really good reputation because when something went well, I gave it away. I gave it away and didn't actively take credit for that. The credit came. It was passive. It came. I got the feel good for it because it came back to me, but I always gave it away. And if something went wrong, I always owned it.
Yeah.
And to this day, 30 years plus later in this system, I'm fairly well respected on both sides on the ambulance side and on the fire side, just because of that. I know in my heart, it's not because I'm a great paramedic. I'm not. I'm a medium paramedic, but because because I've done those things and owned those things, that's why I'm respected.
Yeah.
So
Yeah, I think the very big problem is being a great leader, and then there's like being a dictator.
yeah,
Correct.
Because my personal opinion, to be a good leader, you need to also know when to follow, or like listen to those that you are leading, just like the story you were saying, that's how I've always been. If we're on a cardiac arrest, okay, we've gone through the H's and T's. Anyone else got anything? Or me and my old partners, we'll bounce ideas off each other. But dictators are like, no, we're doing this because I said so.
Mm-hmm.
And then, that could very quickly lose trust and faith into that person. So I think that's one of the biggest things. And then a lot of people that I've noticed have problems with ownership and owning up to their mistakes.
Mm-hmm.
But yeah, I think that's a big problem with, actual leadership, is being a good leader, but being a dictator is the big problem that I've noticed anyway.
Well, I got to tell you, if I make a mistake and I know I made a mistake, you're not going to find out from somebody else. You're going to find out from me.
Yeah, exactly.
Yeah. There's sometimes that I make a mistake and I don't know it, and I find out later.
Yeah.
But if I know that I made the mistake, I'm going to come to you with it and say, I really this up.
But even that, okay, we learned something.
Yeah, exactly.
We learned something today.
Yeah, for sure.
I just had an experience with a newer provider, and she's new, and we had a patient who was already in the ER as a patient move into a recess bay for a medical emergency. And a lot of it was compounded with anxiety. And it wasn't a mistake. It wasn't anything. It was almost, she's still in the running the list of ideas, but we were missing the leadership in the room piece that I got in front of that patient sitting at the foot of the bed. You have an artificial airway in place. We can swell. We can do whatever we want. If that airway's in place, we have a tube in your throat. You can breathe. Look at those numbers. You are breathing. You feel like shit. And we know that. but you can breathe. And then we all walked away and everybody said, oh, wow, I feel a lot more relaxed after that.
Yeah.
But it's sometimes your provider doesn't have time. They're still running the list of, okay, in this situation, I need to make 3 other phone calls to specialists who specialize in this. And somebody else, not a physician, needs to step in and say, we've got this.
Oh, yeah.
You're okay. You are exactly where you need to be. Every once in a while, if you get a patient that's like with it in those bays, you just say gently, you're in a trauma bay at a level 1 trauma center. If you're going to die, here's where you want to do it. This is it. We have all the tools, and calming some of that. Sometimes you just need a leader to call it out, say where you are, say what you're doing, because it's not a mistake that anybody makes. It's just absent that you just, the situation calls for it and you need it and you need somebody to step in. It doesn't have to be a physician.
Yeah. No, 100%. 100%.
What's really cool is when you have a strong team like you guys do, it's amazing, the team that you guys have. What's really cool is when you can say that and have confidence that that person is
doing what she needs to do.
He or she, is over here, doing this, talking, whatever, that you can say in confidence to that patient, you're being cared for by one of the best of the best, and that goes such a long way with the patient.
Yeah.
Yeah. It's huge. That's huge.
And I think that's when you have a great team, somebody notices nobody's actually talked to the patient and told them what's going on, what we're doing about it. And a good team will recognize, and usually that's what happens. Somebody on the team looks at the patient, they're like, this patient has no idea what's going on. Everybody else is focused on all their other tasks, and they talk to the patient. So usually I see that just getting done, because everybody can step into that role. Yeah.
And it doesn't have to be the physician. It could be RT.
Yeah.
It can be the pharmacist who, the patients in this scenario was alert and talking. There was very minimal meds to give in this situation. The meds wasn't the issue. It could have been a pharmacist. It can be anybody, but just trusting too that I knew that physician couldn't do it. Her skill set was completely utilized in outsourcing, getting specialists on the phone, calling and speaking with the specialty pharmacy, doing what she needed to do. So I think sometimes too, we forget that in emergency medicine, it can be the EMS crew that brings a patient in.
Yeah. People feel better when there's a leader at every level. I can't tell you how many times I've had a really sick peri-arrest kind of patient in a trauma bay. And when you reflect on what happened, you see one tech with the younger tech who was immediately grabbing them and saying, like a leader, we need good access. And I realize we don't have this here. I'm going to start here and you should go over there. And they did it. And you're like, that changed their little world. And then you'll see the nurses who are gathered around realizing, I don't have this supply for this, but if you're working on that over there, I'll just meet you there in a minute. And I'm like, look at this. Everybody's leading their world. And then there's just somebody up here who's keeping an eye out or has one skill that needs to be used that somebody else doesn't have. But leadership at all levels makes everybody go home feeling like you did what you could. That's exactly it. It's not leadership. Everybody needs to be a leader in this world.
Yep.
Yeah.
And when you have a team full of people that are looking to lead their own little world, that's when everything comes together perfectly. If you guys got any value out of this today, if it resonated with you, encouraged you, the only thing I ask is you subscribe to the show, give a 5-star rating and review, which will help a ton. I don't make any money on the podcast, and it does cost money to do it. So if you want to support the show, go to practicalems.com, join the email list, and subscribe on any podcast player. You can find the clip stuff on YouTube as well under Practical EMS. And we will see you guys next time.